Okay, thank you very much for the invitation. So today the talk will be about mechanical ventilation. The objectives are to discuss the physiology of respiratory failure, to describe how to tailor mechanical ventilation to different forms of respiratory failure, and to discuss the latest studies defining how to best use mechanical ventilation. This is the outline of my talk. We're going to start off with acute respiratory failure, talk about the equation of motion, talk about variables of inspiration, modes of mechanical ventilation. Then we'll talk about the ARDS, asthma, COPD, and then asynchrony. Throughout the lecture, I'm going to be provide you some questions, and I got those questions from this article from Cox from 2003. Even though the article is old, the questions are still relevant. So, case number one, a 29-year-old lady, 60 kilo, is found unresponsive in a city park after ingesting an unknown substance. Thick sputum is being suctioned from the endotracheal tube. A chest X-ray shows a dense infiltrate in the right lower lobe. She is placed on SIMV. The blood gas shows a pH of 7.43, PCO2 of 36, PO2 of 55, and oxygen saturation of 89% on 100% of FiO2. The primary physiological abnormality accounting for the hypoxemia is A. Excessive dead space ventilation, B. Low cardiac output, C. Intrapulmonar shunt, and D. hypoventilation. And the answer here is intrapulmonar shunt. So there are three types of acute respiratory failure. There is type 1 or hypoxemic respiratory failure, where you have an impairment of oxygen transfer in the lung. There's type 2 or hypercapnic respiratory failure, where you have inadequate ventilation. And there's type 3 or mixed. When you have type 1 respiratory failure, there are a number of mechanisms that can explain that, including low FiO2, if you are climbing mountains, low barometric pressure, diffuse impairment, alveolar hypoventilation, shunt and ventilation perfusion mismatch, which is the most common mechanism. In type 2 or hypercapnic respiratory failure, typically what you have is reduced respiratory drive, increase in dead space, or increase in CO2 production. So how are you going to tease out what type of acute respiratory failure the patient has? So you want to find out whether the hypoxemia is caused by hypoventilation. You want to find out if hypoxemia is caused by hypoventilation, ventilation perfusion mismatch, or right to left shunt. So first you're going to evaluate your PCO2, your alveolar arterial gradient, and the response to 100% oxygen. In hypoventilation, as you know, you're going to have increased PCO2. Normal AA gradient, so your alveolar arterial gradient is going to be normal, and usually there's good response to oxygen. When you have VQ mismatch, your PCO2 is going to be normal or sometimes a bit increased. You're going to have an increased alveolar arterial gradient and moderate response to oxygen. If you have right to left shunt, which is the extreme of VQ mismatch, you're going to have a normal or decreased PCO2, a large AA gradient, and no response to oxygen. Basically, when you have right to left shunt, you have no ventilation, but you continue to have perfusion. And in order to calculate your alveolar arterial gradient, you have to know the alveolar gas equation, which is demonstrated here. So FiO2 times the difference between the atmospheric pressure and the H2O2 pressure, barometric pressure, minus PCO2 divided by respiratory quotient. So here is just showing an example of shunt, where basically you have perfusion but no ventilation, and an example of dead space, where you have ventilation but no perfusion. So case 2, a nurse calls you over to examine the patient because her oxygen saturation has fallen over the past 5 minutes from 94 to 80%, despite an increase in FiO2 to 100%. You notice the breath sounds are audible bilaterally but decreased symmetrically, and there's no wheezing. peak airway pressure has increased to 65 from 40, but plateau pressure is relatively unchanged at 25. Measured respiratory rate is now 42, her heart rate is 110, and her blood pressure is 150/85. So then basically this patient is on the ventilator, and suddenly her peak pressure goes up, but the plateau pressure continues to be normal or low. She is in respiratory distress. What one intervention would be most likely to improve the physiological process causing the patient's hypoxemia? Emergent needle decompression of presumed pneumothorax. B, emergent TPA followed by heparin. C, suction followed by changing the endotracheal tube if no improvement. D, bronchodilators followed by IV solomedrol. And the answer here is suctioning. So in order to understand or to get the right answer here, you have to understand physiology at bedside, and you really have to understand the equation of motion. The equation of motion says that in order for you to provide mechanical ventilation to the patient, there's got to be a driving pressure. And this driving pressure has two components. One component is to overcome the resistance of the airways and the tubing system, and another component is to overcome the recoil of the respiratory system. The first component to overcome the resistance of the airways and tubing system we call resistive pressure. It is flow times resistance. The second component to overcome the recoil of the respiratory system we call elastic pressure, plateau pressure. It's volume divided by system compliance. At bedside, what you're going to have is the total pressure, okay? So the peak pressure, we call that peak pressure or total pressure. You're not going to have the plateau pressure or the resistive pressure at bedside if all you do is just look at the ventilator. So in order to get the elastic pressure, the plateau pressure, you have to eliminate the resistive pressure, okay? And there's a way you can do that at bedside. You do an inspiratory pause. By doing an inspiratory pause, you eliminate flow, and therefore you eliminate the resistive pressure. And then you are left with the plateau pressure. So again, two components here. One is the resistive pressure, another one is the elastic pressure. Once you eliminate the resistive pressure, you are left with the plateau pressure. And then if the patient has a problem of increased resistance, that plateau pressure should be low. Whatever explained, the high peak pressure should be the resistive pressure, right? So a problem of increasing resistance, the plateau pressure should be low. On the other hand, if the problem is decreased compliance, then that plateau pressure is going to be high, close to the peak pressure. So the difference between the peak pressure and the plateau pressure is going to be low if the problem is low compliance. Okay, and you have to understand what are the conditions that cause increased resistance and what are the conditions that cause decreased compliance. For instance, secretion in the endotracheal tube, bronchospasm, kicking of the endotracheal tube, water in the system. Those are conditions that cause increased resistance. Okay, so the plateau pressure should be low, like in this case here. Then you have to understand the conditions that cause decreased compliance. Pneumothorax, bilateral pleural effusion, ARDS, pulmonary edema, abdominal compartment syndrome. All of those conditions are going to cause decreased compliance, in which case your plateau pressure is going to be high. In this particular case, the plateau pressure was low. So out of the options they gave to you, the most appropriate would be, so the plateau pressure is low, so it's a problem of increased resistance. Therefore, the most adequate answer was just suction the airways. So again, a large peak to plateau gradient here would be increased resistance, so you got bronchospasm, suction, etc., etc. On the other hand, if the plateau pressure is elevated, then you have conditions that cause low compliance. So pulmonary edema, ARDS, pneumothorax, atelectasis, etc. So let's go to another case here. In volume assist control ventilation, not pressure. if the respiratory rate is set at 16 breaths per minute and tidal volume 600 cc, what one statement is true of the tidal volume delivered if the patient's measured respiratory rate is 22 breaths per minute? 600 cc every breath. A, 600 cc every breath. B, 600 cc during the 16 set breaths, and the rest determined by patient effort. C, tidal volume will be determined by patient effort each breath. The right answer is A, 600 mL every breath. So that is the fundamental difference between AC and SIMV. In AC, you set a respiratory rate, say 12. Whatever the patient does additional to that, the ventilator will sense and will send to the patient either volume, if you are ventilating the patient volume, or pressure, if you are ventilating the patient pressure. On the other hand, in SIMV, you set a respiratory rate of 12. Whatever the patient does additional to that is on the patient's own effort. Okay? So then another question here, I think in the same line. Which one of the following is true of SIMV? A, the tidal volume of patient trigger breaths above the set rate is determined by the set tidal volume. B, the tidal volume of patient trigger breath above the set rate is determined by patient effort. C, the tidal volume of each breath is determined by patient effort. And the right answer here is B, like we said. So this part of the talk can be a little cumbersome because to some extent there is some memorizing to it, but I think it's important that you guys get familiarized with the terminology. Okay, so let's talk about variables of inspiration. So inspiration is defined by three variables. Trigger, which is the change detected by the ventilator that causes inspiration to begin. Target, which is a value that cannot be exceeded during inspiration. And cycle, which is what terminates inspiration. The trigger can be a patient effort, or it can be the machine. When it's patient effort, we call that assisted breath. When it's the machine, we call that controlled breath. The target can be a set flow or a set inspiratory pressure. And the cycle can be a set volume or a set inspiratory time. With that, you're going to have 4 types of breath: volume control, volume assist, pressure control, and pressure assist. Here it shows volume control type of breath, where your pressure varies from breath to breath. The flow is the target, the value that cannot be exceeded, is constant from breath to breath. And the volume is what cycles and is constant from breath to breath. Volume assist is the same as volume control, except that here the breath was initiated by the patient. In pressure control, the pressure is constant, is the target, and is constant from breath to breath. And the inspiratory time is what cycles, is also constant from breath to breath. Here the flow will be largely determined by the patient and is going to vary from breath to breath. And the volume here will also vary from breath to breath depending on compliance, etc. Pressure assist is similar to pressure control, except that it was initiated by the patient. In pressure support is a little different, but here it is cycle when it has a drop in the flow. So with that, we talked about the 4 types of breath, okay? Volume assist, volume control, pressure assist, and pressure control. And then we talk about now the modes of mechanical ventilation. So you can have a assist control mode, and this assist control might be assist control volume, or volume assist control, or pressure assist control. If you are on volume assist control, you're going to have volume control type of breath and volume assist type of breath. If you are on pressure assist control, you're going to have pressure control type of breath and pressure assist type of breath. Then the other mode is SIMV, which can be volume SIMV and pressure SIMV. If you are on volume SIMV, you can have volume control type of breath, volume assist, pressure support if you add pressure support, and spontaneous. On pressure SIMV, you have pressure control type of breath, pressure assist, pressure support if you add pressure support, and spontaneous. And then finally you have pressure support ventilation. So those are the main modes of mechanical ventilation. So the most common mode of total support is volume assist control or pressure assist control. SIMV is used as well. The problem with SIMV is that it leads to increased work of breathing. In the medical ICU, our patients are very sick, so we tend to avoid SIMV. This was a study that compared assist control with SIMV, and again, it found that assist control tends to lead to more alkalosis and auto-PEEP. SIMV increases the work of breathing. Now, when you talk about modes of mechanical ventilation, a lot of times you talk about, okay, I'm going to put the patient on assist control, but you can do assist control volume and assist control pressure. And what is the advantage and disadvantage of putting the patient on volume versus pressure? So on volume assist control, you're going to assure a minute ventilation. You're going to make sure that the patient gets the minute ventilation you want the patient to get. On the other hand, the disadvantage is that the airway pressure can go very high, so you can get into barotrauma if the compliance decreases. If you are ventilating a patient pressure assist control, for instance, one of the advantages is better tolerance. And why do patients look more better on pressure mode? Because here the flow is determined by the patient, and a lot of asynchrony has to do with flow, okay? Also, when you are ventilating a patient on pressure assist control, you're going to be limiting barotrauma. But the disadvantage, again, is that you're not going to be assuring minute ventilation. If the compliance starts getting worse, the tidal volume the patient will be making is going to get lower. So I got another case here. A 56-year-old lady with diabetes is brought to the ER with a 3-day history of dysuria and low back pain. In the ER, she is confused and tachypneic. Her temperature is 38.9, respiratory rate 28, heart rate 120, blood pressure in the low side 80/50. Her ideal body weight 60 kilos. She has dry mucous membranes. Her white cell count is elevated. Her urine shows lots of white cells with bacteria. So basically, she's got a UTI of sepsis. A chest radiograph shows bilateral interstitial infiltrates with delta effusion. So probably ARDS. Her pH is 7.3, PCO2 25, PO2 62, and her oxygen saturation is 90. You start her on IV fluids and antibiotics, and you feel that ventilatory support is indicated. Which one of the following would be the most appropriate form of ventilatory support at this time? A. Non-invasive positive pressure ventilation by face mask. B. Intubation, volume assist control, ventilation, respiratory rate of 20, tidal volume of 360. C. Intubation, intermittent mandatory ventilation, respiratory rate 20, tidal volume of 700 cc. So the right answer is B. I think this question is really asking two things, okay? Number one is, if you have a patient in frank respiratory failure with ARDS, you're better off intubating the patient. The data for non-invasive ventilation for ARDS is not that strong. There is some data actually showing that it may be detrimental because you may end up delaying intubation. So if you have a patient full-blown acute respiratory failure from ARDS, the general feel is that you're better off just intubating and connecting the patient to the ventilator as opposed to keep trying non-invasive ventilation. Then the second thing this question is asking is, and by the way, this is good for your life, this is good for the boards as well, because this type of question they like to ask in the boards. They are not going to tell you the patient has ARDS. They're going to present a case, and from that you have to recognize the patient is in ARDS, and then, as you know, ARDS, you got to ventilate with low tidal volume, 60 cc per kilo of ideal body weight. So we'll talk a little bit about ARDS, okay? So first I'm going to give you the old definition of ARDS. Acute onset of respiratory failure, bilateral infiltrate on the chest X-ray. In the past, we used to have the term acute lung injury when the PO2 FiO2 was less than 300. And then ARDS was reserved for PO2 FiO2 less than 200. And all of this should not be from heart failure. Okay, so that is the old definition for ARDS. In 2012, there was a meeting and they redefined ARDS. It's pretty similar with some changes. So the time frame, still, ARDS is an acute process within a week. Okay, the patient develops respiratory failure within a week. On the chest X-ray, you got bilateral infiltrates. The edema must not be from the heart. So you got to have some sort of objective evidence showing that, this is not heart failure, like a brain natriuretic peptide or maybe an echocardiogram. And then now the term acute lung injury has been abandoned, and we have ARDS for PO2 FiO2 ratio less than 300, okay? And then you have some grades of severity, mild when this ratio is between 200 and 300, moderate when this ratio is between 100 and 200, and CV when it's less than 100. And all of these, you gotta have at least a PEEP of 5, okay? So if the patient is not intubated on a CPAP of 5 or pressure support and PEEP with a PEEP of 5. So when you talk about the pathogenesis of ARDS, you're going to have diffuse alveolar damage. If you do biopsy of patients with ARDS, that's what the pathologist is going to find. There's a lot of inflammation, release of cytokines. It is a neutrophilic inflammation. There's damage to the capillary endothelium. There is edema, of course. Also, the surfactant in patients with ARDS is dysfunctional. All of these will lead to the cardinal manifestations of ARDS, which is hypoxemia, so impaired gas exchange, decreased lung compliance, and a lot of times these patients will also develop pulmonary hypertension while they have ARDS. ARDS is a heterogeneous entity. I think it's important to recognize that because prognosis varies a lot depending on the etiology of ARDS. For instance, if you have ARDS from aspiration, the prognosis is very good. If you have ARDS from pancreatitis or sepsis, then the prognosis is not as good. Okay? And we like to classify ARDS into pulmonary and extrapulmonary etiologies. For instance, pulmonary etiology, pneumonia, aspiration, pulmonary contusion, and extrapulmonary sepsis, pancreatitis, etc. From a physiological standpoint, there is a difference between extrapulmonary and pulmonary. Extrapulmonary ARDS tends to cause more ground glass changes, as opposed to dense consolidations in pulmonary. Extrapulmonary ARDS tend to be more responsive to PEEP. When you put a patient on a ventilator, you're going to cause lung injury, okay? Every patient who is on the ventilator is at risk of developing lung injury, and this is even more true when you have a patient with ARDS, okay? And it's important that you all understand the mechanisms by which a ventilator can cause lung injury. And basically there are 4 mechanisms, okay? There is overdistension or volutrauma, there is increased transpulmonary pressure or barotrauma, and there is atelectrauma, so the closing and opening of the airways will release a lot of inflammatory cytokines, and that is also detrimental. And there's a 4th one that is not here in this slide, but it's oxygen toxicity. We think oxygen is toxic to the lung, particularly if the FiO2 is above 50%. This is the pressure volume curve of the respiratory system in a patient with ARDS. On the x-axis you have the pressure, and the y-axis you have the volume. You can see that this curve is a sigmoid one, okay? And you have 2 points. You have a low inflection point and an upper deflection point. Below the low inflection point, you see a lot of change in pressure for very little change in volume. What does that mean? That means this is area of low compliance, right? So compliance is volume divided by pressure. Above this low inflection point, then you have a area of good compliance, and then above the upper deflection point, again, you have an area of a lot of change in pressure for very little change in volume, so an area of low compliance. Below the low inflection point, what you're going to be getting is a lot of atelectrauma, so the opening and closing of the airways release inflammatory cytokines. Above the upper deflection point, you're going to get barotrauma and volutrauma. So where you want to ventilate the patient, you want to ventilate the patient between the low inflection point and the upper deflection point, between these 2 points. So then how are you going to achieve that? So you're going to achieve that by low tidal volume, so you avoid going beyond the upper deflection point, by using PEEP, so you're above the low inflection point, okay? So that is the rationale behind the strategy of ventilating patients with ARDS. Low tidal volume and use of PEEP, okay? As a result of the low tidal volume, you end up retaining carbon dioxide, and that's okay. We call that permissive hypercapnia. Actually, some experts feel that there is some hemodynamic benefit to that. And then so it makes sense from a physiological standpoint, and the question is, do we have data for that? And there is data. It's now old, actually. The clinical trial done here in the United States was in 2000, and they were comparing low tidal volume against what used to be traditional tidal volume at that point in patients with ARDS. So I'm going to go over the ARDS network protocol, because I think you guys need to know. You're going to be in the front line in the MICU. You need to know this protocol by heart. Okay? So the tidal volume, first of all, should be based on predicted body weight, calculated from sex and height. So the first thing I ask you guys to do when you come to the MICU is have that formula available. So for every patient of yours, you calculate the predicted body weight. The tidal volume, 4 to 6 mL per kilo of predicted body weight to maintain a plateau pressure equal less than 30. So if you have a patient 60 cc per kilo of predicted body weight and your plateau pressure is still above 30, you can go further down the tidal volume. In patients with ARDS, the respiratory rate usually has to be high. They have low compliance, you're ventilating, then with low tidal volume, the dead space is increased. They're going to retain a lot of carbon dioxide. So you need to ventilate these patients typically with a respiratory rate 24, sometimes 28. And what you want to do is just keep your pH above 7.3. That's the ARDS protocol. Here in the ICU, you like to keep above 7.25. Okay? And then how you going to titrate your FiO2? According to the ARDS protocol, you need to keep the pulse ox above 88 or the PO2 above 55. You don't want to keep the patient on a high FiO2 unnecessarily. Okay, so you always want to keep going down in FiO2 as long as your pulse ox is above 88, the pulse ox above 88, or the PO2 above 55. And the PEEP you're going to choose is going to be based on how much of FiO2 the patient is requiring to keep this oxygenation. So there is a PEEP FiO2 table that you're going to be using at bedside to select the PEEP you want your patient to get. So in this study, the group that had low tidal volume had a significant decrease in mortality, so it was 31 versus 40%. This was a landmark study, large study, NIH-sponsored, multi-center, so you can't get better than that when it comes to clinical evidence. So this changed practice, basically. Then, this study that I just presented compared 6 cc versus 12 cc. Then subsequently, people start to ask, well, 6 cc is better than 12 cc, but is 6 cc per kilo better than 8 cc per kilo? And the answer is yes, it is. The lower your tidal volume, the better. There is now many observational studies showing that the lower your tidal volume, the better. And this is another study showing that if you have a patient being ventilated with 6 cc per kilo for 8 days, and then you have another patient being ventilated with 8 cc per kilo for 8 days, the mortality goes up by 2.7. If you are going to ventilate a patient with 10 cc per kilo, your mortality is going to go up by 7.2%. So very good data that you really want to keep your tidal volume 6 cc per kilo or less, okay? Then the question that comes up is, okay, so this is good for ARDS. What about other patients? And the answer is any patient that comes to ICU should have 6 cc per kilo of predicted body weight. Maybe with one or two exceptions, a patient with impending brain herniation, etc. But for the overwhelming majority of the patients, you want to ventilate these patients with 6 cc per kilo. This is a meta-analysis in patients who did not have ARDS showing a decrease in mortality. So then the next question here to you guys. A patient of ARDS is being managed on volume assist control mode of ventilation. Blood pressure is 100/70 and heart rate is 90. While sedated, have peak arterial pressure 40 and plateau pressure 24. On an FiO2 of 60% at people of 5, a blood gas reveals a pH of 7.28, PCO2 of 36, PO2 of 55, and oxygen saturation of 85. What one of the following would be the most appropriate next measure? So would you increase the FiO2 to 80? B, would increase the tidal volume by 100 cc from your initial setting? C, would you increase the rate by 4 breaths per minute from your initial setting? D, increase the PEEP to 10. And the answer is D, increase the PEEP to 10. So that has to do with recognizing that increasing the tidal volume is harmful, recognizing that you want to avoid oxygen toxicity, recognizing that the use of PEEP is beneficial, recognizing that you can use the PEEP FiO2 table to kind of tailor or decide how much of PEEP you're going to use on your patients. This was just a study done here in the US that compared a high PEEP versus low PEEP. Please notice that low PEEP doesn't mean a PEEP of 5 here. It means a PEEP from 5 to 24, okay? And a high PEEP meant a PEEP from 12 to 24, okay? So when we talk about low PEEP here, we're not talking about a PEEP of 5. The mean PEEP was 14.7 the group of in the high PEEP group, and 8.9 in the low PEEP group. So those are the tables that they used. They would tailor or select the PEEP according to the FiO2 that was required to keep the oxygenation we already talked about, a pulse ox above 88, a PO2 above 55. In this particular study, there was no change in mortality between the two groups. Then there are two other studies, two other big clinical trials that looked into different levels of PEEP in patients of ARDS. And then there was a meta-analysis of individual patient data that showed that if you have ARDS that is moderate or severe, you're better off using the high PEEP FiO2 table. So if your PO2 FiO2 ratio is less than 200, you're better off using the high PEEP FiO2 table. If, on the other hand, your PO2 FiO2 ratio is above 200, you can use the low PEEP FiO2 table. They found a decrease in mortality using the high PEEP in patients who had moderate or severe ARDS. So we're going to change a little bit the topic from ARDS to asthma. As you know, asthma is a chronic inflammatory disorder of the airways. It is characterized by airway hyperresponsiveness, airflow limitation, atopy, which is which is a predisposing factor for asthma, and a lot of times it is triggered. The exacerbations are triggered by viral respiratory infections. So that is a common cause of asthma exacerbation. So when you ventilate a patient for asthma, the primary goal should be to reduce dynamic hyperinflation. And a common mistake we see, in the ER or sometimes in the ICU is that you get a patient with obstructive lung disease who's being just ventilated, and the provider or the physician, the first thing that comes to the physician mind is to correct the acidosis. And that should not be your primary objective when you are ventilating a patient with asthma. The primary objective is to reduce the degree of dynamic hyperinflation. What happens is that these patients, they have very prolonged expiratory time. So you provide them a tidal volume of the ventilator, and they don't have enough time to exhale that tidal volume. And that keeps accumulating. They get another tidal volume, not enough time to exhale. Again, to the point that sometimes they can develop hemodynamic instability and could even die from that. So your primary objective is decrease the degree of dynamic hyperinflation, not correct the acidosis in the blood gas. You also want to minimize the risk of barotrauma, and you want to make sure the patient is synchronous with the ventilator. So then how are you going to avoid hyperinflation? Basically, you have to increase the expiratory time of the patient, right? The most effective way of increasing the expiratory time of the patient is just decreasing decreasing the respiratory rate, using a low respiratory rate. So that's different from the patient with ARDS, where you typically use a high respiratory rate. Here you want to use a low respiratory rate, okay? Also, if you increase the flow, that means that there's going to be a shorter time to provide the volume that you want a patient to receive. So high flow, we typically ventilate patients with obstructive lung disease with high flow. Finally, if you use a low tidal volume, that's going to lead to less time for you to deliver that tidal volume. So low tidal volume as well. But the most effective way is just low respiratory rate. But you want to use all of these strategies together. This is just showing how effective you can be in preventing dynamic hyperinflation or auto-PEEP just by decreasing the respiratory rate here from 15 to 10. You can see here with a respiratory rate of 15, the flow time curve doesn't go back to baseline, meaning the patient was auto-PEEPing, and once you decrease the respiratory rate, you're good to go. So we talked about early on that when you have conditions that decrease the airway resistance, you're going to have an increase in the resistive pressure. Your plateau pressure should be fine, should be low, right? We talked about that. Asthma is one of those conditions that increase airway resistance. However, if you start auto-PEEPing, then your plateau pressure is going to go high if you start auto-PEEPing. So you can use surrogates to see if the patient is auto-PEEP. You can actually calculate the auto-PEEP, and you do that by doing expiratory pulse on the ventilator, or you can just look at the plateau pressure as a surrogate as to whether the patient is auto-PEEPing. So again, you can do expiratory pulse, and you can find if the patient is auto-PEEPing, right? You're going to have the total PEEP, and then you have your set PEEP, you subtract that, and then you get the auto-PEEP. Or you can do an inspiratory pulse, and like I said, asthma is a condition that causes increased airway resistance. You should not have a high plateau pressure, except if you start auto-PEEPing. Then your plateau pressure is going to start going up. So this is just, again, showing a flow time curve, showing that it doesn't go back to baseline, and therefore this patient is auto-PEEPing. So this is just an algorithm as to how ventilate a patient with asthma. I found that interesting. First of all, you're going to use a tidal volume. I think I would use 60 cc per kilo as opposed to 7 to 8, okay? Your respiratory rate is going to be low, 12, 14. Your flow is going to be high, I would say 60 to 70, okay? You start off with FiO2 of 100% and use a PEEP of 5. And then you can use the plateau pressure as a surrogate as to whether the patient is auto-PEEPing. And if the patient is not auto-PEEPing, that's a good thing. If the plateau pressure is less than 30, that's a good thing. So plateau pressure less than 30 is here. So if the plateau pressure is less than 30, that's a good thing. You look at your pH is above 7.2, you're good to go. So a pH above 7.2 is acceptable. Look at this, 7.2. If on the other hand, your pH is above is below 7.2, if your pH is below 7.2, then that is a little too acidotic. Okay, then you want to increase your respiratory rate. As you increase your respiratory rate, you're going to run into risk of auto-PEEP. So you're going to be looking at your plateau pressure. And so increase your respiratory rate until your plateau pressure is above 30. And if your pH is now above 7.2, you're good. If below 7.2, you're in trouble, you could consider bicarbonate drip, although this is controversial. Okay? On the other hand, if you start off, your plateau pressure is above 30, you're in trouble, right? Your patient is auto-PEEPing. So you're going to go ahead and decrease your respiratory rate even further, increase the flow. Then you look at your pH. If your pH is above 7.2, you're good. If your pH is less than 7.2, you're in trouble. You can use some bicarbonate drip, but again, controversial here. So another case here. 64-year-old lady with COPD presents to the ER with increasing shortness of breath. She's in moderate respiratory distress. Her temperature is 38, heart rate 110, respiratory rate 28, blood pressure 110/70. She's using accessory muscles to breathe but can complete short sentences. Chest X-ray shows hyperinflation and decreased lung markings throughout both lung fields. A blood gas shows a pH, blood gas on 2 liters per minute of oxygen. pH of 7.3, PCO2 of 60, PO2 of 58, and oxygen saturation 88. In addition to close monitoring, which one of the following interventions would be most appropriate this time? A. Increase supplemental oxygen with continuous beta-agonist therapy. B. Continuous beta-agonist therapy only. C. Intubation, mechanical ventilation. D. Non-invasive positive pressure ventilation. And the answer here is non-invasive positive pressure ventilation. So basically, what this question is about is a patient of COPD with acute hypercapnic respiratory failure. In a situation like that, non-invasive positive pressure ventilation is highly, highly beneficial. So let's go over the definition of COPD. So it's a condition characterized by persistent airflow limitation. So it's not intermittent like asthma. Here it's persistent, it's progressive. It is associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. So, talking about non-invasive ventilation in COPD, we have robust data supporting the use of non-invasive ventilation in COPD. It improves carbon dioxide elimination. It unloads the respiratory muscles that are on the edge, that are impeding respiratory failure. So you need to treat 8 patients to prevent 1 death in patients with COPD exacerbation who come with acute hypercapnic respiratory failure. That is very substantial. This is very remarkable. 8 patients to save 1. So who benefits the most from non-invasive ventilation? So patients with moderate respiratory acidosis, a pH less than 7.35. Most patients, in reality, most patients with pH between 7.3 and 7.35, they will survive even without non-invasive ventilation. But by doing non-invasive ventilation, a patient like that, you're going to prevent one intubation out of every 10 patients that you treat. So that is remarkable as well. So it should be strongly encouraged, anyone with a pH less than 7.3. If you have a pH of 7.2, some observational studies say that perhaps you're going to be delaying intubation on these patients and might potentially be dangerous. I feel that it's still beneficial, it's still worth giving it a trial, even if your pH is low, as long as the patient can cooperate, as long as the patient is not too obtunded. But one thing that is very important when you talk about non-invasive ventilation is that you need to have a close monitoring. It's not good to put a patient with acute respiratory failure on non-invasive ventilation, leave that patient for a couple of hours, and then go back to reevaluate the patient. If you're going to put a patient on non-invasive positive pressure ventilation for acute respiratory failure, you need, before you start that, you need to evaluate the patient's mental status, the respiratory rate, the use of accessory muscles, and the blood gas. And then you put the patient on non-invasive positive pressure ventilation, and 1 hour later you come at bedside and reevaluate all of these parameters, including the blood gas. And if there is no improvement, that should raise a major red flag that perhaps that patient will need to be intubated. Okay, guys? So when you talk about invasive mechanical ventilation for COPD, it's very similar to asthma. All you want to do here is decrease the degree of dynamic hyperinflation. So then the strategy, you start with a tidal volume of 6 cc per kilo, a respiratory rate of 10 to 12, high flow. Some experts feel that if you're going to ventilate a patient with obstructive lung disease, you are better off using a pressure mode, like assist control pressure, because here then the flow will be determined by the patient, and therefore the patient may be more synchronous with the ventilator, more comfortable. So I'm going to finish here talking a little bit about patient-ventilator asynchrony. So this is a mismatch between the patient and ventilator inspiratory and expiratory times. The prevalence is 10 to 25% of ventilated patients. And the most common pattern is ineffective triggering, which occurs in 85% of the cases of patient-ventilator asynchrony. Double triggering is also relatively common, 13%. Then you have other mechanisms, auto-triggering, short cycle, and prolonged cycle. This is a case of double triggering. We have 2 inspiratory phases and just 1 expiration. This is usually, this double triggering usually occurs when the tidal volume is set a little too low, or the patient's ventilatory demand is too high, or the flow is too low. So then, this will lead to stacked breath, increased work of breathing. So what can you do to correct that? Well, you could go up in the tidal volume. You can try to interact with the flow. Like I said, a lot of times the flow might be a little too high. Sometimes if you change the patient to a spontaneous mode, the patient will become more comfortable. The other mismatch is ineffective triggering, you see here. So what causes ineffective triggering? If the patient is weak, or also very importantly, if there is auto-PEEP. Okay, so if there is auto-PEEP, a lot of times the patient will not be able to trigger the ventilator. So it leads to increased work of breathing. And what can you do to fix that? You can decrease the sensitivity of the trigger, okay? In order for the patient to trigger the machine, the machine has to sense a change in flow or pressure, okay? And for instance, if you set the machine to sense a change of -2, that is better than if you set the machine to sense a change of -4. So the patient, it will be easier for the patient to trigger the machine. Sometimes if the reason why the patient is having ineffective triggering is auto-PEEP, you can increase the set PEEP to about 80% of the auto-PEEP, and that will help the patient to trigger the ventilator. Then auto-triggering can be caused by cardiac oscillation, bronchopleural fistula, water condensation in the ventilator circuit leak, and leak of the endotracheal tube cuff. So just to conclude what we talked about the importance of using low tidal volume and PEEP in ARDS. We talked about the importance of recognizing the mechanisms of ventilation-induced lung injury. We talked about how you want to avoid dynamic hyperinflation in patients with obstructive lung disease. Thank you.